Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock.
Hello.
And senior reporter, Kimberley Hackett.
Hi, everyone.
We've got a really packed show today, lots and lots of things going on at the minute. Coming up, we're talking about the BMA ballot on collective action, which launches next month, and what the general election could mean for that and general practice more widely. We'll be discussing the Royal College of GP's call for an overhaul of GP funding so that it better addresses health inequalities, and a wider report the college has produced on how to reverse the inverse care law. And we'll be rounding up what went on at last week's UK LMCs conference. Our good news story this week is about a scheme in London that's been prescribing fruit and veg to patients on low incomes and with long-term conditions that's seen some really impressive results. That's all to come on this episode of Talking General Practice. First up, in the time since our last news podcast, the BMA has announced that it will ballot GP partner members in England on taking collective action in the next step in its dispute with NHS England and the government over the 2024-25 GP contract. And we're now in the early stages of a 6-week general election campaign that will no doubt see the NHS fairly high up the agenda. So what does all this mean for general practice? Nick, first off, let's start with the BMA ballot, and then perhaps we can look at what the general election means for that. So what exactly is the BMA balloting on, and what will happen if the ballot backs collective action?
So, as you said, the BMA is balloting GPs on collective action. The ballot will open next month on the 17th of June and run through almost to the end of July, to the 29th of July. Before I talk through what this is all about, though, it's just worth recapping on what's brought the profession to this point, to the brink of this form of action. The GP contract for 24-25, the current financial year, was imposed on general practice by the government. It's actually the third year in a row in which contract changes have been imposed. And what that means is that the government and the BMA did not reach an agreement over the terms of the contract. So the government effectively said unilaterally, this is what you're getting. And for 2024-25, the key sticking point was, as has often been the case in previous years, the level of funding the government was prepared to put in. The BMA GP leaders said general practice needed an uplift of around 8.7% in the current financial year to overall contract funding, to bring practices back to the financial position they were in 2018-19 after years of real terms funding cuts. But the contract that was imposed on the profession came with a sub-inflationary 1.9% uplift. So that means another real terms financial loss for practices. And it's one that GP leaders have said will trigger practice closures, cuts to staff and services. The BMA actually said when it launched the ballot that it was aware of practices that have already decided to hand their contracts back since this contract was imposed. So it's already having that impact. So that's what pushed GPs to this point. And I'll come on in a minute to talk a bit more about how this general practice ballot differs from the BMA ballots over industrial action by other branches of the medical profession in recent months, such as junior doctors and consultants. But for general practice, this is the next phase after a referendum on the contract for 2024-25 that the BMA carried out in March. More than 99% of around 19,000 GPs who took part in that referendum voted to reject the contract. So we know almost no GP in England is happy with the contract for the current financial year. The referendum showed the strength of feeling across the profession, and now the BMA is moving on effectively to what GPs are going to do about it. The referendum was open to all GPs, that's partners, salaried GPs, locums, GPs in any role. But this ballot is for partners only. So these are the GPs who run practices, who hold contracts to run practices. And the BMA is now moving to find out what actions these doctors are willing to take to push for better funding for general practice. One point to mention here is that of the doctors who voted in the referendum, 3/4 were actually partners. So we know that among partners, the vast majority absolutely reject the contract. This ballot, though, will be seeking support for specific types of action to fight back against it. So it's a slightly different question. And the result is maybe not the foregone conclusion that the referendum result probably was.
Do we know what we're talking about when we talk about collective action? The BMA has said that this is action that means GPs won't be breaching their contracts, but do we know exactly what that means?
The difference between this ballot and the ones for junior doctors and consultants in recent months is that this is non-statutory. So whereas junior doctors and consultants have gone on strike with the protection of a statutory industrial action ballot behind them, the action by GPs, for now at least, will be quite different. GPs will not be asked to take action that will breach practice contracts at this stage. And that's why the BMA is talking about collective action rather than strikes or industrial action. The BMA England GP committee is currently looking into the types of action practices would support, but it's listed some of the potential forms that this could take. So practices could limit the number of patient appointments per GP per day to the recognised safe working limit of 25. The BMA has actually been encouraging practices to do that anyway for nearly a decade now. But I think it's fair to say that most haven't done it. And obviously, many GPs are delivering far more appointments per day than that limit. GP practices could also stop or reduce work that they're not formally contracted to do. Things like tasks that have been dumped on them by hospitals or other providers that practices often just do without any funding. The BMA says this could include things like refusing to complete fit notes, prescriptions, or investigations that should have been completed in hospitals. It could also include asking hospital trusts to communicate with patients about rebooking hospital appointments rather than practices just doing that themselves. GP Online's also done some polling that gives us an insight into the forms of action GPs might be willing to take. Our survey suggested 3/4 of GPs were prepared to take part in some form of industrial action. I mentioned the BMA idea of practices adopting safe working limits en masse as a form of action, and that was the most widely supported response according to our survey. So 84% of people who were prepared to take action said they were ready to do that. And around 3 in 5 supported other actions such as partial or complete list closure or handing in their notice on things like shared care agreements.
And so what does the general election mean for all of this? Will it affect the ballot?
It's an interesting one. The BMA GP committee says the election doesn't affect its plans for the ballot. And that's certainly true in the sense that the ballot is going ahead on the same date that they originally planned. The fact that the ballot was announced only a week before Rishi Sunak popped up with this surprise announcement that a general election would go ahead on the 4th of July definitely affects planning around how to make sure the ballot sends the strongest possible message and that it ultimately delivers what the profession wants, which is restoration of funding. Meaning initially a reversal of erosion of funding over the past 5 years and then ultimately the bigger erosion over the past 15 years. Earlier this year, when GP leaders were still planning the referendum on the contract and a potential ballot, the BMA's expectation, and probably lots of other people's to be fair, was that an election wouldn't happen until much, much later in the year. And the idea was that GPs could be taking collective action during the general election campaign in the hope that this would make general practice a real doorstep issue during the election. But because of this surprise early election date, the ballot won't actually close until almost 4 weeks after the election. So the threat of collective action will be a lever that general practice can use against the next government, but not against the current one. So what the BMA is saying, though, is that because the ballot will open just over 2 weeks before the election day, campaigning, encouraging GP partners to vote in favour of collective action will mean that messages about the crisis facing general practice and underfunding will be promoted heavily during the election campaign, and that can be the way for GPs to make sure that their profession is still a doorstep issue in the run-up to the 4th of July. Another thing to mention here is that although the 2024-25 GP contract came with a 1.9% uplift, the government has said that a further uplift could come based on advice from the Doctors and Dentists Review Body, the DDRB. And that's an independent body that advises the government on pay and funding for doctors. The DDRB puts out a report each year, having weighed up evidence from the government, the BMA, NHS England and others, and makes recommendations on pay for the medical workforce. Uplifts to the GP contract funding have been largely outside the remit of the DDRB for the past 5 years because of the 5-year contract that began in 2019. And that had locked in uplifts for each year within that period. But this year, the DDRB will make recommendations on an uplift to the overall GP contract and for partners. as well as the recommendations it's been making in recent years around uplifts to pay for salaried staff. So recommendations from the DDRB usually emerge in July. Last year, its report came out on the 13th of July. So the report is likely to be sitting in the in tray of a new government the day after the election. The BMA England GP committee chair said this week that she expected the DDRB would recommend something like a 4% uplift on top of the existing 1.9%, meaning practices would in the end receive roughly a 6% overall uplift for 2024-25. This is still well short of the 8.7% the BMA wanted for this year, and the BMA has suggested it would leave the profession around £350 million short in real terms of the funding level in 2018-19. So even if a new government implements the DDRB advice, if it is what the BMA GP committee chair predicts, that won't go far enough. And the ballot on collective action then could still be a powerful tool to push for a better deal for general practice, whoever is in Downing Street after the 4th of July.
Yeah, well, there's definitely going to be a change of personnel, I would imagine, in the Department of Health, whoever wins. We know that Andrea Leadsom, who has been the minister responsible for primary care, is actually standing down at this election. And so she's the person that the BMA has been dealing with in discussions about funding for the GP contract up until now. So there will be a new minister in that post, whichever party wins the election. But how much control they have over what the Treasury decides to release will obviously depend on who's ultimately in charge in number 10. You actually spoke to some GPs last week about their views about the timing of the election. What did they have to say?
So I think the biggest concern for GPs was that the timing of the election could ultimately delay implementation of any further funding uplift, both for general practice and the wider NHS. So we've already seen, for example, junior doctors announcing new strike dates to coincide with the run-up to the general election, much like GP's original plan, really, to take action during the election campaign. But junior doctors' action has been announced because the mediation process that they just started to go into with the government over their long-running pay dispute has been scuppered by the election being announced. And since the government won't carry on talks, they're returning to action and clearly hoping to make an impact during the general election. For GPs, the issue is around the DDRB advice. If the DDRB report is sitting in the new government's in tray, how long will it take for the new Health and Social Care Secretary to get the nod from a new Chancellor to implement what it says? So that's a big concern. Could any further uplift to this year's contract be pushed back? But GPs also said they welcome the election as a chance for change. That's a word that Labour will probably be quite glad to hear people using. And several were really positive about the prospect of using campaigning around the ballot to raise the profile of the challenges facing general practice as well.
Obviously, we've yet to see any manifestos. It's still quite early in the campaign, but I'm sure the NHS and general practice will be fairly high up on all of the political parties' manifestos. So obviously, we'll be keeping an eye out for them. We're going to come on to talk about the LMCs conference, last week's UK LMCs conference, in a bit more detail later. But there was a particularly important vote at the end of the conference last Friday that relates to what we're talking about here. This was about mass resignation. What happened in that vote and what were GP leaders saying during that debate?
This was a vote at the UK LMCs conference, which took place in Wales last week. And I think it reflects the fact that although the referendum and the ballot of GP partners over collective action have been concentrated in England, anger about underfunding and staffing in general practice runs deep right across the UK. The motion that LMCs passed said governments across the 4 UK nations had failed to provide the necessary investment to ensure the survival of GMS, the GMS contract that most practices operate under. And they voted to give GP leaders across the UK their backing to use the threat of mass resignation from the profession, basically the threat of practices collectively handing back their contracts to get a better deal for general practice. There's actually a recent example of undated contract resignations being collected from GP practices within the UK. It's about 7 years ago in Northern Ireland. And at that point, I think they said 97% of practices were prepared to hand in undated contract resignations at one point, and they did begin to collect them as a form of leverage in contract negotiations. They didn't come to the stage of actually handing those in, fortunately, but that was a threat that was being used. And the motion that was carried at this UK LMCs conference said that being prepared to walk away may be more effective than industrial action or collective action. And one of the speakers said the threat of GPs going dental, so moving to a model more like dentistry with a sort of mixed private NHS model, could be a powerful lever for negotiators to use. So there's this idea of having to have a plan for an alternative to the current model of delivery. And LMC's actually called for BMA GP committees across the UK to develop viable alternatives to GMS, including actively supporting GP practices to work outside the NHS. So it really is a threat to go nuclear and leave the NHS if things don't improve. Let's be clear, almost no one wants to see that happen, but BMA England GP Committee Chair Dr. Katie Bramwell-Stainer spoke really powerfully at the conference about the way general practice was being treated and what the profession was pushing back against. This is a phrase she's used before, but she told the conference that we're witnessing the constructive dismissal of our profession on a national scale, that this was intentional, premeditated and planned. She also said that no political party would deliver the £660 million uplift that general practice needs to bring it back to real terms levels of funding it had in 2019 until they have to. So again, really emphasising that despite the way the timing has worked out with the ballot and the election, having a vote for action in the bag can only strengthen GP's position, whoever the profession is negotiating with over the sort of year or more ahead. The BMA Wales GP Committee Chair, Dr. Gareth Earlman, also spoke about it being vital that although separate GP committees across the UK are negotiating contracts with different governments, the profession needs to stand united across the UK. And he said that for GPs across the UK, securing the funding and support that the profession needs depends on organisation and being prepared to act collectively. He actually said that the mood of the profession across all four nations was pushing GPs further and further towards taking industrial collective action. So it's really a clear message that GPs across the UK are ready to stand up for better resources.
That's actually a really important point, isn't it? Is that we've talked very much about what's going on in England in this section. And obviously the general election will have the biggest impact in England because this is the government the English BMA will have to negotiate with in terms of funding and the GP contract. But we should not forget that all parts of the UK, in Wales, in Scotland and in Northern Ireland, there are real problems and issues around funding, workforce, the contracts there, that the BMA GP committees in those countries are having their own negotiations with the governments there to resolve. And obviously the general election will have an impact in those countries as well in terms of the types of the levels of funding that feeds through to the devolved nations in terms of what they then have available to spend on the NHS. But anyway, in terms of what's going on in England, the BMA has a series of roadshows planned during June and July. As part of this, the BMA GP committee executive team will be going out to meet grassroots GPs to explain the ballot, what it means, and also to hear what GPs think need to happen. The GP committee is also planning apparently to put out a GP practice survival toolkit, which it says will help practices to protect their practices and patients. Presumably, this will probably be setting out how some of this collective action will work. And the committee also says it will include campaign materials that I expect will be related to educating patients about the issues and challenges facing general practice. Obviously, you'd think they'd be trying to get that out pretty quickly now if they can, so that the material is out there and in practices for patients to see during the general election.
Survival toolkit sounds a bit like tins of spam and Swiss Army knives or something.
Maybe that's what will be in practice waiting rooms when we go and visit our GP next. Over the next few weeks, the general election campaigning will obviously be ramping up and we'll be covering everything of interest relating to general practice and the NHS on our website. We've set up a dedicated section for that and you can find all our election coverage on GPonline.com/election 2024. Before we move on, just to let you know that there's still time to book a place to attend MIMS Learning Live London, which takes place next Friday, the 7th of June at the Business Design Centre. Organised by our colleagues on MIMS Learning, the event is free to attend for healthcare professionals working in primary care. This year's programme features streams across 4 key therapy areas: dermatology, women's health, respiratory and cardiovascular renal metabolic medicine. With expert speakers who'll provide you with actionable insights for immediate application in your practice. There'll be plenty of opportunities to ask questions and network with colleagues. Register for your free place at mimslearninglive.com. Moving on, we've spoken on the podcast in the past about the RCGP's manifesto, which sets out the 7 steps it believes are needed to save general practice, and which it will be pushing for prospective MPs to sign up to during this election campaign. Among other things, it calls for a £2 billion investment in GP premises, a black alert system for primary care to trigger support for practices if they're at risk of being overwhelmed, an increase in the number of GPs, and steps to address the visa problems affecting international medical graduate newly qualified GPs. It also calls for primary care to receive a greater share of NHS funding, and then for more of that funding increase to go towards practices in deprived areas in a bid to tackle health inequalities. Last week, the RCGP, alongside the Health Foundation and Patient Voices, wrote to the government just before the general election was called, demanding an urgent review of GP funding to address inequalities. Kimberley, you wrote about this. What exactly was the college asking for?
So the organisations asked for 3 key income streams for general practice to be reviewed to better account for areas of high deprivation. First of all, they want the Cahill formula, which is used to distribute core practice funding, to be reviewed and reformed. Then we have the QOF and performance scheme targets that the organisations who wrote the letter say can be harder to hit for practices in area of socio-economic deprivation. And the so-called financial reward may not provide practices that are serving the more socio-economically deprived areas with the correct resources. Because of this, they want a revision in the way these indicators are measured. And there has also been a call for a change to the way PCNs are funded so that once again deprivation is taken into account. The organisations have said that without these changes, GPs working in deprived areas will not have the resources they need to care for patients. Now, it's important to highlight that practices in areas of deprivation are more likely to have, on average, 300 more patients per fully qualified GP than practices in areas of low levels of deprivation. According to the letter, 37% of GPs have said they are unlikely to be working in the next 5 years. The RCGP says that the loss of these GPs are likely to be felt more acutely by practices in areas of high deprivation. Now, this has understandably worried the letter's signatories, and they have said that with targeted investment, it will be more of an incentive for GPs to work in undoctored and socio-economically deprived areas.
We already know, don't we, that there is a greater shortage of GPs in areas of high deprivation. There's been an argument for quite a long time about funding needing to change to sort of recognise that. The letter really did make quite a compelling case for why this needs to change. What did RCGP Chair Camilla Hawthorne have to say about it?
She said that without the government addressing the funding structure, health inequalities will continue to grow. She also explained that GPs have seen the gap growing between the richest and poorest patients' health, which has been made even worse by the ongoing cost of living crisis. And she said that GPs are reporting that they are spending more time dealing with issues that are directly linked to poverty, such as obesity, drug and alcohol misuse, and mental health conditions like depression and anxiety. She warned that in areas where there are fewer GPs per patient, it has meant there is less ability to provide the continuity of care that patients need.
Nick, you and I have been writing about GP funding for more years than I care to mention, but there's been a real recognition for quite a long time now that the way practices are funded, that it doesn't really properly reflect deprivation. I mean, this is probably true for many aspects of funding that GPs receive, but the formula which decides how much they are paid for core general practice, which Kimberley mentioned earlier, the Cahill formula, really doesn't take account of the extra work that practices will inevitably need to undertake if they're in a deprived area, does it?
That's right. The Cahill formula has been criticised for some time for failing to recognise the impact of deprivation on GP workload. Dr. Bex Fisher, who's a GP and a policy expert at the Health Foundation think tank, said a few years ago that the Cahill formula was the root cause of underfunding for general practice in deprived areas. One of the points in the manifesto published last year by the RCGP, which you mentioned a minute ago, was that practices in the poorest communities have 14% more patients per GP, but get 7% less funding. And Bex Fisher told MPs a couple of years back that for every 10% increase in deprivation in the population they serve, practices get something like a 0.06% increase in funding. So it's barely reflected at all. Age is a much, much bigger factor in the formula. But what that tends to mean is that in better off areas where people live longer, funding for general practice is higher, whereas in areas where life expectancy is shorter, but often people are living with more long-term conditions at an earlier stage, the demand that creates is not reflected in the funding. So there's been pressure to review the Cahill for some time, but it actually plays a bigger role than ever now in determining practice funding. It came in 2004 when what was called the new GMS contract took effect, and practices moved away from the previous item of service funding model. But for about 15 years after that, most practices received top-ups through a system called the Minimum Practice Income Guarantee, and it was basically so that they weren't disadvantaged compared with historic levels of funding that they received. But that guarantee was phased out from 2020, so core funding is now properly delivered through Cahill with all of the unfairness that entails.
There's also real question marks over PCN funding and other funding as well, isn't there, as Kimberley mentioned there, and whether that is really distributed in a way that would help tackle health inequalities. What are some of the problems there?
So the RCGP and others say that PCNs in areas with high deprivation have less funding and staff than PCNs in areas with low deprivation. And again, that this is linked to problems with the way funding is allocated. The Health Foundation think tank said last year that PCNs in the 20% most deprived areas of England employ 6 fewer full-time equivalent staff per 100,000 patients than those in the 20% least deprived areas. And they also said that the current way funding is distributed to PCNs doesn't use the best available formula for taking into account patient deprivation. If a different formula was used, one that's already in use in the NHS to distribute some primary care funding for ICBs, the Health Foundation says that PCNs in the most deprived areas would collectively receive £18.6 million more funding per year. So ultimately, there's plenty of evidence to show how big an impact deprivation has on need and GP workload, but not enough is being done as things stand to make sure that it's factored in adequately when it comes to slicing up the pie of general practice funding.
It's a really important issue. It's just been going on for such a long time. We must be reaching a point where someone's going to have to address this funding inequality. So the RCGP sent that open letter to the government, and then the following day it launched a report called Breaking the Inverse Care Law in General Practice across the UK, which was actually the day after the general election was called. And for anyone listening who doesn't know, the inverse care law is a term that was first coined by GP Dr. Julian Tudor Hart over 50 years ago, which describes how people who most need healthcare are the least likely to receive it. The RCGP report sets out in more detail some of the arguments that we've discussed here as to how and why GP funding needs to be reformed in order to tackle the inverse care law. And clearly, that, as I said, that's the most important thing that needs to be addressed if we're going to address health inequalities. But there are some other interesting points that are made in the report, which I think are also worth highlighting. So these are other things, as well as funding, that the college says needs to change. So the report makes a series of recommendations about things. Access is one area where they say that policymakers and commissioners need to make sure that there's no inequalities around access, streamline registration, and improve support for addressing barriers to access. Also, workforce, that the government needs to evaluate existing GP recruitment and retention schemes to make sure that they are really working properly in areas of high deprivation, and basically to look at implementing new schemes where needed, and additional funding, much like the targeted recruitment funding we've seen before, to encourage GPs to go and work in those areas of higher deprivation. Also using data to properly understand local communities and what is going on there and how they can address health inequalities. And also, really, the other big thing is to actually tackle the social determinants of health. And obviously, much of that work is outside the gift of general practice. That is policy that government needs to take in a cross-government approach to really tackle the many problems that lead people in areas of deprivation to suffer from greater levels of ill health earlier in life. But anyway, it's a really good report, actually, I think, and hopefully something that ministers and the future government will take on board. So I'll put a link to that in the notes for this episode. So in a week or so of quite a lot of news, it was also the UK Local Medical Committee conference last week, which took place over 2 days in Wales. The conference debated a number of issues that apply across the UK, and the general theme really of many of those debates was perhaps unsurprisingly the workload and workforce crisis and underfunding of general practice, because as we mentioned earlier, these are issues in all four of the home nations. One issue, though, that is very particular to England that was also widely discussed is the unemployment crisis, which is something we've talked about many times on the podcast in recent months. Just as a quick recap, this is a problem sessional GPs, so salaried GPs and locum GPs, are facing in many parts of England because even though we are in the midst of a GP shortage, practices just can't afford to employ them. Kimberley, you watched the speech given by BMA Sessional GP Committee lead, Dr. Mark Steggles, and you spoke to him afterwards while you were at the event. What did he have to say to you about this?
So in April, the BMA called for the government to investigate the GP unemployment crisis, and Dr. Steggles told me that the government still hasn't responded to this call. Now, despite the government's silence, he said that the BMA is still pushing ahead with raising awareness about the job crisis with the public and the government. He told me he wants the public to know that there are GPs currently out of work, and this is because of chronic underfunding and that practices can't afford to employ GPs despite wanting to. Once again, he called for the additional roles reimbursement scheme funding to be expanded to include GPs and nurses, but he said that whenever the BMA brings this up with the government, the union comes up against a brick wall and there is no budge. Dr. Steggles also told me that the job shortage crisis means it is a really worrying time for GP registrars qualifying this year. He had even heard of one GP vacancy receiving 80 applications. He said that the job shortage could lead to our new GPs going abroad or into the private sector, which he described as a waste of skills and talent.
I definitely got the sense it's something that GP registrars are really worried about. Obviously, we've got huge numbers due to qualify this summer, and I heard several delegates raising that issue during the event. I mean, one GP stood up and said there were basically no GP vacancies at all in his area. Dr. Malinga Ratwat, who is the chair of the BMA GP Registrar Committee, said the unemployment crisis posed a significant threat to the sustainability of the profession. He said that what was once a brilliant career choice with steadfast job security was now under threat, and there was a real feeling of a lack of optimism about the future of general practice among GP registrars, which is really quite depressing. He also actually called on LMCs to call for an end to ring-fenced additional roles reimbursement scheme funding, like Dr. Steggles, so that practices have got greater freedom to decide who they want to recruit with that money, namely GPs. I think he would like to see them using that money for. Nick, we know there's a real concern about how the ARRS is affecting employment opportunities for GPs. Obviously, lots of concerns about physicians' associates in particular, which we've talked about on the podcast before, and how they are being used in general practice. There was also a debate during the conference specifically about the PA role. What were delegates saying during that, and what did they vote on?
LMCs voted in favour of a motion expressing growing concern about the development and promotion of physician associates in general practice. The motion said GPs cannot and should not be replaced by PAs, and it accused the GMC, in fact, of complicity in a government plan to create an inferior model of general practice by using PAs in place of GPs. As you said, I mean, this issue is a really big one for general practice at the moment. The BMA has been warning for some time that there's growing evidence GPs are being replaced by physician associates. And the NAO said earlier this year too that the NHS workforce plan was built on substitution of GPs. I mean, it didn't mean just by physician associates. It meant by a whole range of staff that are employed through the additional roles reimbursement scheme. And it also meant by supplementing the workforce with an increased number of GP registrars, so GPs or doctors who are working in general practice but are not yet fully qualified GPs. GPs have been arguing hard that the $1.4 billion a year in funding available through the additional roles reimbursement scheme should be made available to pay for recruiting GPs and practice nurses, as you've mentioned, as Kimberley just mentioned, warning that the fact that money has been ring-fenced for non-medical staff at a time when core funding has been eroded has created this situation we've been reporting on, in which qualified GPs are struggling to find work despite the fact that practices are under a huge pressure. Those GPs are out of work because, as you've said, practices can't afford to recruit them. But they have ring-fenced money available through PCNs to bring in other ARS staff. So that's what's happening. This was a motion calling out that situation again. And in terms of the claim that the GMC is complicit in this, that's a reference to the fact that the GMC is in the process of taking on regulation of medical associate professionals, including PAs. And that's something the BMA says it shouldn't do. And the BMA said that this risks blurring the lines between doctors and non-doctors and adding to confusion among patients around who is actually delivering their care. And the GMC, for its part, has said that everyone agrees PAs need to be regulated and that it will make clear that they're different from doctors. And one of the ways they're going to do this is with a prefix on their registration number. But as things stand, legislation making the GMC responsible for regulating PAs will take effect at the end of this year.
I actually watched the debate. They had a wide-ranging debate. It wasn't a debate about motions. It was GPs standing up and talking about the workforce crisis. And one of the things I found quite interesting at the end of that, Dr. Alan Stout, the GP committee chair for Northern Ireland, he was one of the members of the GP Executive Committee who was sat on the top table. And at the end of that debate, he did actually say it was really interesting for the people from the Celtic nations to hear about the experience of doctors in England of the ARRS. And he said it is something that we would really resist being introduced, I think, in Northern Ireland. And I would imagine Wales and Scotland would be very much in alignment with that, about making sure a scheme like that didn't come to those countries because of the unintended consequences we've seen in England in recent months. Anyway, I mentioned at the start of this section that the focus obviously was on issues that are affecting general practice across all 4 UK countries. That really came across in the speeches by the co-chairs of the UK GP committee, Dr. Alan Stout, who I mentioned there, and Dr. Andrew Buist, who's the GPC chair in Scotland. Nick, you were watching that. What did they say?
That did really come across. They made the point that across the UK, despite the fact that contracts have diverged over the past decade or so, and despite the fact that GP committees in each of the 4 UK nations are negotiating with a different government, the fundamental problems are exactly the same everywhere. And no prizes for guessing that those problems are chronic underfunding and workload pressure. And I think a point that came across really strongly was a message that it's for politicians, not GPs, to save the NHS. I mean, we've spoken a lot about GPs working longer and longer hours, partners cutting their drawings and so on. And basically, governments leaning hard on the goodwill of GPs and practices to maintain services despite big real terms reductions in funding. So the point Dr. Stout made was that GPs can't keep doing more with less forever. GPs can't hold themselves responsible either for services that are deteriorating because of a lack of resources. And therefore, it's up to politicians ultimately to save the NHS by stepping in and fixing the underfunding. And Dr. Buist said general practice was under attack from politicians who are either seeking to damage the model of universal free access to a GP or who just don't understand the value of what GPs do. And I mean, I guess that speaks to the point that Katie Bramall-Stainer made, just the sense that this is premeditated. The BMA feels that there's an agenda behind all this. And ultimately, from these two, the message was very much that general practice across the UK needs to stick together and push for better funding across all 4 nations at the same time.
Yeah, I mean, there were lots of other motions that were debated that were also really interesting, including, one that I followed about safe working limits, calling on the government to recognise them, which I found really interesting, and calls for an overhaul of violent patient schemes that were backed, and another one that backed calls for a directed enhanced service for safeguarding work, which it turned out is something the GP committee in England had asked for in this year's contract negotiations and will be asking for again next year. So you can read all about that and all of our coverage from the UK LMCs conference on GPonline.com, and we'll put a link to the full coverage page from that conference in the notes for this episode. Before we go, we've just got time for our good news story, which is about a pioneering scheme in London that sees GPs and their teams prescribing fruit and vegetables to patients. The programme is the first UK trial of such an initiative, and it's been taking place at a practice in Tower Hamlets in East London and Lambeth in South London. Both boroughs have high levels of poverty, child poverty, income inequality and health inequality. It's been funded by local authorities and the Alexandra Rose charity, which runs the programme. The scheme began in November 22, and last week the charity published the results of the trial. Around 200 people participated in the scheme, which saw them issued with up to £8 in Rose vouchers each week, plus an additional £2 for each household member to spend on fruit or veg of their choice at local markets and food co-ops. Most of the participants had one or more long-term conditions, and the vast majority were also living in food poverty. After 8 months of receiving the vouchers, 80% of participants were eating 5 portions of fruit and veg a day, compared with just 28% before the programme started. 90% of people said they had experienced an improvement in their physical health, which included weight loss and higher energy levels. 7 in 10 people with high blood pressure saw an improvement in their condition, and over half of participants said their mental health had improved because they worried less about having money for food. The programme was run alongside social prescribing services, and the charity said that both of those things together had led to a 40% reduction in GP visits from those people who took part. The scheme also meant that money was spent in the local economy, so there was also a real benefit to the traders who took part. Campaigners have now called for the scheme to be rolled out across the UK. I mean, it really is such a brilliant idea, and there were lots of other benefits as well, such as better engagement with health and support services from the people who took part because they had to come in to collect their vouchers. You can read more about this on our website, and we'll also put a link to the final report from that project in the notes for this episode. Well, that's it for this week. Thanks for listening, and thanks to Nick and Kimberley. I'll be back next week when I'm speaking to Dr. Farnaz Sharif about well-being among doctors and staff in primary care and the importance of mental resilience, so please do join me then. In the meantime, you can keep up to date with all the latest news affecting general practice, including our coverage of the general election on our website at GPonline.com.